You're listening to the Physio Matters podcast in association with EOS Active, and this is session 104. Welcome back to Physio Matters. I'm still Jack Chew. When we did 100 monthly consecutives for the Physio Matters long form, we said we'd bring you specials when something came across our desk that just suited the format, and this is definitely one of those. The topic of joint and soft tissue injections, as to what substance to inject, when, where, and the nuances around that is a fascinating subject, and one that's come back to the fore as we understand some of the implications of steroid on chondrotoxicity, the emergence of ever better hyaluronic acid products, which have a better safety profile, major controversies ongoing over the utility of PRP, and studies for and against that of varying qualities. And so it just seems smart to get stuck into that subject matter more thoroughly. In doing so, we've been talking to Jim Carr from EOS Active, really interesting company that's emerged recently. And we did a Chewing It Over episode with him a couple of weeks ago, so go and check that out if you're interested in more about what they're about as a company. Jim introduced us to orthopedic surgeon Bilal Barkatali, and he was local to us, so it was great to get back into the podcast studio in full and have a really good deep dive conversation into all these matters. One of the things that I found really interesting and definitely room for a follow-up on this topic is that when we got to things like PRP, it's a long time since I've taken a deep dive into that literature or given lots of thought to the mechanisms of effect in that direction. So I felt a little bit underqualified to challenge there or to have an appropriate back and forth over the efficacy on that with someone that uses it on such a regular basis. And so that was definitely an area where, and we spoke about this afterwards, where we could come back and do more on that if you guys are interested. So if there's any parts of this conversation that you'd like us to zoom in closer on, then me and Bilal are happy to thrash that out again because I think it's a fascinating subject that we need to get right as an industry. But yeah, massive thanks to EOS Active. Do check them out, eosactive.co.uk. We'll check the pod description for more details on them. Really interesting, and they've got some really interesting products, including ones that we talked about in this podcast, namely Singal, which I've used a couple of times recently, and very impressive. And something that I'm fascinated to see its emergence, and obviously the more data comes in, but also the more experience we have using it, it's going to be a really interesting innovation that I'm keen for you to all get on top of, because you know what I'm like, just want to raise standards in MSK practice, and I think this is a mechanism of doing so. I'm not one for fads and gimmicks and lurching from whatever might be the trend, often seen as being a bit of a slower adopter when it comes to interventions. I'm a bit of a traditionalist on the rehab side, as you know, and so it's been an interesting thing for me to look into the evidence as well as then understanding the current dilemmas we have as to what we might inject and not. Certainly found myself very interested in what EOS Active and Jim Carr are doing at the moment over there. So without further ado, here's Bilal Barkatali and me chatting about all things injections. I'll see you at the other side. Delighted to be back on the Physio Matters mics in person, which is nice. This place has been a glorified Zoom studio for too long recently, and so I'm pleased to be able to chat about hyaluronic acid. Really interesting space at the moment because of the timing of news as to what things are doing at the various different joints, but particularly evidence emerging at the knee. So delighted to have you here, Bilal, to talk about that. Could you introduce yourself for the listeners first and foremost?
Yeah, sure. So my name is Bilal Barkatali. I'm a consultant specialist knee surgeon. I've been a consultant since 2014. And obviously trained for many years before that. And my specialist area is all of knee surgery with particular reference to joint preservation. Okay, so I guess that's the main focus of what we're going to be talking about today. I do other knee surgery as well, such as sports, ACL, patellofemoral work, osteotomy, etc. Osteotomy and realignment surgery is part of the joint preservation umbrella. As well as injection therapy, and I guess we're going to be focusing on injection therapy and conservative measures and how we can preserve knees and avoid knee replacement surgery, which is a great passion of mine.
And how did it become such a passion of yours within that space?
So all knee surgeons are trained to do knee replacements as the baseline, a big operation that we do. And the incidence of osteoarthritis and the severity and how it affects people, that's been increasing over the decades. And so the total knee replacement operation in itself has been around for a long time. We do a lot of it, but it's not without problems, okay? So the risk profile and sometimes the actual functional outcome at the end of it is not where we want it to be. So in my opinion and in my training, in my experience, I only like doing that operation when it's going to work for that patient, okay? And so there's a correct time to do it when the knee is degenerate enough. You've got fixed flexion deformity, you've got reduced range of movement, you've got constant pain. In those situations, a total knee replacement operation is a great operation and will do wonders for that particular patient, get them back moving, doing the things they want to do. But there's a wrong time to do that operation. You can do it too early when you haven't got any of those parameters like fixed flexion deformity or constant pain. And so the human knee joint, in my opinion, is far superior to a prosthesis that's placed to mimic that joint, okay? So if you can hold on to your own knee for as long as possible, for me, that's the best possible option. And so there are many strategies that we can employ to try and hold on to it and keep the function and symptoms under control for as long as possible.
What are your primary reasons for considering that superiority of the biological knee joint?
So the primary reasons are the ligament balancing around the joint, okay? So if you try and imagine a knee joint, it's basically a long bone, a femur, resting on top of another long bone, the tibia, with the soft tissues around the joint providing the balance throughout the range of movement during walking, climbing and descending stairs, running, twisting and turning. How can you do all of those things whilst these two bones are resting on top of each other? It's all about the soft tissues and the ligaments, okay? And so the human knee joint is a very complex interplay of all those ligamentous arrangements and relationships, and that can't be mimicked successfully using a prosthesis, okay? So on that basis, it's always better to hold onto your own knee for as long as possible.
Okay. And so over the years, we've seen various different interventions, be that on a surgical level, on a rehab level, as well as then the in-betweens when it comes to, say, injections or medicines, as well as then braces and beyond.
Sure.
Could you just give me an insight into how your sort of view of each of those things, you don't have to go in turn, but just a general sense over the years as to how things have evolved in your thinking and your practice?
So I think we've come a long way, okay? I think that's the first statement I'd like to make. We've come a long way in the last 15, 20 years in how we approach the degenerate knee, okay? So really what we're talking about is the degenerate knee. And the way I look at it is levels of degeneration, and they've been quantified in lots of different ways, okay? So the basic classification is a Kellgren-Lawrence classification, KL grading on weight-bearing x-rays, okay? And that's a very good way to define where you are in that particular patient's degenerate knee pathway. Now, in the past, and when I was first started training, not that much consideration was given to whereabouts that patient is in that pathway. The treatment pathway would be, right, you've got arthritis, okay, we're not going to do a knee replacement just yet. We're going to give you some steroids, okay? And so there was no bracing. There was no emphasis on muscle bulk, proprioception, strength, range of movement. So we were well behind in terms of approaching it with a rehab point of view. It was basically, here's an injection into your joint, see you in 4 to 6 months, and we'll do another injection. And patients were managed quite badly for a number of years, usually between 2 and 3 years in that way, until the knee would be completely degenerate, the cartilage is completely gone, the joint has collapsed, there's constant pain, poor function, then you have no choice but to have a knee replacement, right? So what have we achieved in the meantime? Okay, so we've started to now appreciate that you can do things to slow down the osteoarthritic process. You can support the patient to get back to doing what they want to do. And so all of these factors, such as proper assessment from a good physiotherapist, gait and biomechanical interpretation of what's happening, other joint involvement, bracing. There's a role of bracing if you've got mechanical malalignment, varus or valgus knees with unicompartmental wear. Bracing can really help in that interim period. And then on top of all of that, what can we do in terms of symptomatic relief and how do we slow down the osteoarthritis. Things like reducing BMI, core strength, etc., go a long way. And then on top of all of that, pre-surgery is injection therapy. And the three main options now in my book. Steroids still have a role to play. Hyaluronic acid injections have increased over the years. And in the last 5 to 10 years, the role of PRP, platelet-rich plasma, also has a role to play as well.
Brilliant. And we'll definitely be zooming in on those injectable options shortly. If we can just jump onto the surgery in a sense, but probably avoiding TKR for this conversation. But in that time frame, the proliferation and then waning again of the washout, the arthroscope, the debridement in general. What's your personal sort of take on how that's been in your profession?
Yeah, so I think in the 90s and early mid-2000s, in that era, there was a lack of evidence around what we should be doing in terms of arthroscopic treatment of arthritis, okay? And there's a lot of good anecdotal evidence of patients who I've ended up doing knee replacement surgery on who had a washout of the knee and a clear out of the knee, and they benefited from it, right? So we can't say that, oh, it was a really terrible thing to do and we shouldn't have done it, right? Because for a lot of people it did work, but then you have to weigh up the health economics of what you're doing. And performing an operation on someone, even something as minor as a knee arthroscopy, involves a lot of resources, time in theatre, equipment, time out for the patient. And those operations were effective, but only for a short period of time. Okay, so in some patients, they may work for 12 months plus. In some patients, they'd work not at all or for a few weeks only. Okay, and the rationale for doing them is to take the inflammatory. So once you wash out a knee, you've taken all the debris and the inflammatory load out of the joint, and it feels better. Okay, but that is not a long-term treatment or solution for that particular pathology. And so, rightly so, that treatment has completely fallen out of favor, and you'd struggle to find any good orthopedic knee surgeon who would still be offering a clean out or debridement of the knee as a surgical solution for knee arthritis. Okay, now, there is a spectrum of pathology. So with early degeneration, you can get meniscal pathology in the joint, for example. Okay, so now there's a lot of confusion sometimes out there in the literature and in discussions when you go to conferences, etc., about the degenerate meniscal tear. Now, the degenerate meniscal tear can be part of an osteoarthritic picture. If you've got osteoarthritis and a degenerate tear, which you will do, you shouldn't be doing a scope on that knee to treat the meniscal tear or whatever, because that falls into the same category as a knee washout for arthritis. But you can have meniscus tears that are degenerate in older people, 40 plus, okay, that cause mechanical symptoms and problems. And for those people, it's perfectly feasible and right to do an arthroscopy, treat the meniscus tear in an otherwise healthy knee and get that patient going again. And they're very separate issues and situations, and then shouldn't be confused. But the washout for osteoarthritis and debridement, that is out. That should not be done anymore.
And so that ends up falling into a category then of various things that showed promise and had some transient results. However, unfortunately, in the fullness of time and further study, makes us realise that there's, for various reasons, it's not wise for us to lean in that direction. Yeah. And so instead, we end up with sometimes a significant gap between a total knee replacement and then quality conservative management and rehabilitation. And so injections have ended up being in the mixer for that middle ground, and that it doesn't have to be either or. It's poor pathway management for them to not overlap, and for those conversations not to be multidisciplinary. How have you seen injections then, if we try and still play the timeline game, as to where things have come both in and out of fashion, but also in and out of an evidence backing? So how's that been over the last whatever time frame we would decide?
Well, so just to close off the arthroscopic debridement operation, I mean, we can always look back, right, through time with critical thinking in eyes, but without criticizing the people who were there at that time making those decisions. So I'm never critical of people who did that previously. But we evolve and we grow and we use evidence-based to tailor our treatment for these types of patients, and that's what's happened. So one treatment has fallen out of favor because we've shown actually it's not beneficial in the medium to long term to do that. And then that has left, as you've pointed out, quite a large space of a treatment gap of the degenerate knee that is not ready for a knee replacement operation. And because of that gap and its existence, other treatment modalities have come to the fore and backed by evidence as well. And so I guess this is now a good time to discuss what they are. And so, as we mentioned previously, steroids was the mainstay of this treatment gap, but hyaluronic acid, especially, and PRP, and in the world, PRP can still be quite a controversial topic to talk about because there's a lot of evidence out there for it, for both for and against. Okay, so it's not as clear cut as hyaluronic acid, for example, and even that can be debated. But there is strong evidence for all three treatment modalities to fill that gap, and that evidence is building for the last 10 to 15 years.
So let's just go to steroids to start with, because I think certainly I don't have the data in front of me, as well as it not being well collected in terms of the sort of amount of injections going into knees as we speak. The majority of those, especially in this country, would be steroid, and that has varied in terms of the particular type, dosage, etc. But we've increasingly starting to realise. I mean, in my space, we realised it a few years ago to much of our blushers with tennis elbow. We realised about the way in which that really deteriorated long-term outcomes, and that we had some serious regret where we'd been a bit trigger happy with the syringes there. Yeah. And that to some extent it feels like only a few years later we're starting to see an emergence of an evidence base that suggests a similar effect in the degenerative knee as well, although still an evolving picture. Yeah. You quite rightly have said that there's still a role to play. So what we want to make sure, and I want to try and tease out the reasoning, is how do we make sure we're not so nihilistic as to therefore wipe it off and start making, doing an apology tour for having done them before? Like, where is the space for
Where's
it?
The space? Okay, so let's start with steroids. That's a good place to start. That's been the king of injections for decades, right? We've used steroids for 40 plus years in MSK treatment. And as you say, nobody should be vilified for that. But let's work out where it now belongs in our treatment pathway. I think that's the correct thing to do. So in all three types of injections, there are multiple factors that come into play when treating a patient. Okay, so the main factor for me is the extent of the osteoarthritis in the joint. Okay, so a proper assessment physically in terms of symptoms and x-rays. Okay, so weight-bearing x-rays of the knee joint for me is absolutely mandatory before going out injecting anybody. Okay, so lesson number one from this conversation should be either have the ability to request imaging or work with somebody that you can refer to get initial imaging of a knee joint before you start treating it. So that's the golden number one rule. Okay, so then based on those weight-bearing x-rays and patient factors, we need to decide, is this patient an early mild osteoarthritic degenerate picture? Is it moderate or is it severe? Okay, because knowing that then guides the treatment. Okay, so the aim of the game is to preserve the joint. Now, you touched on it briefly about steroids and some deleterious effects steroids can have on connective tissue. Okay, so how do steroids work? Steroids, just generally speaking, offer good pain relief and a reduction in the inflammation that is caused by the osteoarthritic process. Okay, so what happens in an arthritic joint? The synovial lining and the soft tissues are inflamed because of the inflammatory process that is part of osteoarthritis. The way steroids work is they reduce that inflammation by reducing the vascular permeability of those soft tissues. So what you get is a calming down. It's no longer hot, it's no longer warm, it's no longer painful. And that's the main mode of action of steroids. Okay, so when you inject an inflamed joint, whether it's from osteoarthritis or from rheumatoid or whatever, it will feel better because you've reduced that inflammation and the pain pathways. And so it will feel better, and that's great. Okay, it feels good. You can get out and do whatever you want to do for a bit. Okay, now a single shot steroid injection won't cause any long-term negative effects on the cartilage, or on the ligaments or the tissues that are surrounding the joint. But repeated steroid injections really affect the catabolic pathways that are required to rebuild soft tissues, tendons, ligaments, cartilage, etc. So by disrupting those pathways, you're no longer able to regenerate and naturally heal those tissues. And so what you get is a destruction of the cartilage. The cartilage is the holy grail in the joint. That's what you want to protect. So by repeatedly injecting the steroids, you get a degradation of the substance of the cartilage, which then leads to a very quick pathway to a knee replacement operation. Okay, so we've established that, we know that repeat steroid injections are not a good idea. Okay, but a single injection, if you've got runaway inflammation, okay, the joint is warm, painful, very tender, a single injection is not a bad thing to do. And so for me now, that's where the steroid injection sits in the pathway. So if you want to do a single injection, one a year or one every couple of years, if nothing else is working, that's fine. Once you get to, okay, we're going to do this every 12 weeks or every 16 weeks, that is a one-way ticket to a knee replacement operation.
And so what is the sweet spot in time frame for that? And is that based purely on the pragmatics of each case and their needs and what else is or isn't working?
Yeah.
Is it based on the profile of that patient extended into their weight, their background inflammation, there was the systemic factors? Just if you can just unpack a little bit more of the profile.
Yeah. So when would I do a steroid injection, I guess, is the question. Okay. So we've mentioned the level of the osteoarthritis, so I'll just touch a bit more on that. If it's very early osteoarthritis or very late, okay, so if you've got end stage, very late osteoarthritis, and the patient does not want any surgical intervention at that time, there's no cartilage left to preserve, okay? So all you've got left in that joint is widespread destruction, joint space loss, and a lot of inflammation causing pain. Now, you're not going to cure all the pain by doing a steroid injection, but you can help them in the short to medium term by injecting steroid, which will calm the knee down. They're going to be having a knee replacement anyway. You're not trying to preserve anything, so you haven't lost anything by doing that, okay? So end stage, grade 4 bone-on-bone osteoarthritis is fine to inject steroid to see if it helps with the inflammation and for a short-term relief, okay? The rationale there is the joint's already gone. You're not trying to save anything. Steroids are, the main pro points of steroids are they're cheap, okay, they're easily available. They're available everywhere for anybody to do, and they're easily administered, okay? So they are still accessible to clinicians, and that's a strong plus point. But just choosing the right patient and the right situation to inject them is the difficult area. So end-stage arthritis, where they're going to be getting an operation anyway, is fine to do so, with the caveat that you explain to the patient that they can't have surgery for at least 4 to 6 months following a steroid injection due to the increased infection profile following the injection and going on to surgery. Okay, so just always remember that. So that's end stage. What about early, mild, moderate osteoarthritis? Where do steroids fit into that? Now, in my opinion, they don't have a very large role to play in early, mild, or moderate osteoarthritis. In those situations where you've got cartilage in the joint, try not to inject steroid, okay? The only place for steroid in those types of patients is if you've got a lot of inflammation. So you examine them, it's very warm, it's inflamed, and you want to get on top of that inflammation, then a single shot, sometimes mixed with hyaluronic acid, is the only indication.
Right, that's great, and that does take us naturally onto hyaluronic acid as probably next in the chat. What's the sort of timeline on your use of it? Is it something that you started out experimenting as the evidence was emergent? Is there an evidential threshold that it had to pass for it to be the first put into one of your syringes? Just if you can give me the sort of insights into your own practice to start with. Yeah,
so I touched on availability there for steroids. They are freely available. Hyaluronic acid is slightly less available. And when I first started out in training and as a consultant, hyaluronic acid was available within the NHS on the shelf. You could do it in clinic, okay? And then there was some nice guidance which stopped that availability from from happening, from being available, and they were removed from easy access in NHS clinics, etc. Privately, they're available through prescription. So accessibility and availability of any of these is always a factor to consider. Okay, so when they were available, we were putting them in, and this is around early period of my training and as a consultant. When we were doing a lot of steroid injections as well. And then in our minds, we were thinking, which is the right injection to do here? Is it steroid? Is it hyaluronic acid? And so hyaluronic acid was less used, but then because we started to understand steroids and their role in the destruction of the cartilage more and more, the use of steroids became less and the use of hyaluronic acid became more. And there was a gradual shift between one and the other in the early, mild and moderate cases of osteoarthritis. And so the reason to inject hyaluronic acid is that it doesn't have any drugs in it, right? So it's a relatively inert, very gentle, very kind injection to be able to do. It acts as a great lubricant in the joint. It acts as a cushion. It increases the viscosity of the existing synovial fluid. It helps the synovial lining, the synoviocytes, to create more healthy synovial fluid for the joint. It coats the lining of the synovium and the chondral surfaces, and that results in reduction in pain sensation and the firing of the pain receptors in the joint. And so whatever happens, you don't lose anything ever by injecting hyaluronic acid. There's no negative or downsides to it because it's such a joint-friendly injection to be able to do. And all the research shows that actually it has a positive effect on the quality of the synovial fluid and also pain scores and function for 4 to 6 months.
In preparation for this chat and thinking in this direction for the last week or so, I was wondering how much it was that hyaluronic acid came to the fore as an injectable, because it is a synthetic version of our synovial fluid. And how, on a biochemical profile, how similar are they, and does that matter anyway?
Well, so the working molecule in hyaluronic acid is the hyaluronan molecule, right? Now, hyaluronan exists in all of your connective tissues. It's not just around the knee joint or in cartilage. It's in all of your connective tissues. It's in your brain. It's in your eyes. It's in your skin. It's everywhere. It's a natural building block of connective tissue and glycosaminoglycans, right? So it exists in your body everywhere naturally anyway, right? Where it was originally derived from was from roosters. You know, the what do you call it? The thing that roosters. Yes, the thing they have on their head. It's a connective tissue. Yeah, so I've forgotten what it's called, but that's where it's naturally derived from and processed from. But then there's a synthetic way to develop the hyaluronan molecule, which is essentially the same molecule.
Okay. Yeah. And so then when it comes to it's interesting then when we're thinking about it not having any direct biological cost, and we'll no doubt come to the pragmatic application of it. Then involves actual cost to the person if it's something that's then delivered privately, particularly in this country. Yeah. But when then we're thinking about, in the same terms as the steroid, the profile of patient of which it's then applicable, does it naturally then? Is there a profile of patient and a behaviour of that joint that makes it then more indicated than, say, a steroid?
So patient factors always are to be considered. So in both, for me, the 3 injections represent a spectrum of approach, right? So you've got steroids, which are active drug-based agents that affect the inflammatory pathway. Then in the middle, you've got hyaluronic acid, and which is on the spectrum heading towards a more biological approach. And then we'll come on to PRP and platelets shortly, I imagine, but that's on the other end of the biological spectrum. And hyaluronic acid occupies a space right in the middle, okay? And so the right time to inject that is in all levels of osteoarthritis. You can even inject it in grade 4 because it, again, helps with dampening down inflammation in the joint, okay? The effect of it becomes less effective the worse the osteoarthritis is, okay? So in grade 4, it's less likely to work for longer periods. But again, if a patient doesn't want surgery, or wants to delay surgery, or wants to try something non-surgical, it's perfectly well placed to give some benefit for a period of time. And then in terms of when does it work best, what's the perfect patient to apply it in? The perfect patient will be somebody active with a normal BMI, who looks after themselves, good core strength, good gait and posture, and they've now got what looks like degeneration in the joint, early to mild degeneration, and that will work beautifully in that profile.
In a bit of a deep dive to the evidence, it's something that we can all understand on an anecdotal and an applied basis, especially with an ability to pick patients based on our own detailed assessment, and that ends up being where the rubber hits the road in clinic and really matters. But it's sensible on an evidential basis that we sometimes need to try to control for things and to try and understand then based on some diagnostic profile and threshold that meets an intervention. Hyaluronic acid has sometimes struggled to better, say, saline, which is increasingly shown to not be inert, and we can talk a bit about that if you wish. But just out of interest, I know that an argument that I've looked at is that the molecular weight of the hyaluronic acid and the quality of that product is something that needs to be taken into consideration with the literature there. Is that an opinion you hold? And could you just unpack that a bit further for the audience?
Yeah, no, I'm in the direct agreement with what you've just said. Okay, right. So not all hyaluronic acid is the same. Okay, so the manufacturing process, etc., and the weight, the molecular weight of the hyaluron used within that particular HA injection. Now, there are many different varieties and companies that produce hyaluronic acid. Now, the molecular weight, and this is shown in scientific papers, is that if the molecular weight is below a certain weight, so it's 400,000 Daltons. So the Dalton is the unit used to measure molecular weight in hyaluronic acid and other molecular weights. If it's below 400,000, it's too small to do anything to the synovial lining or stimulate the synovial lining and the synoviocytes. Okay, if it's too big, then it's too big to stimulate the synoviocytes and synovial lining. The key aim is that the hyaluron will stimulate the synoviocytes to create more healthy synovial fluid in the joint. Okay, that's one of its main modes of action. So if it's too small, below 400,000, it won't do anything. If it's too big, I think it's 5 million Daltons, then it's too big to stimulate it. So the sweet spot's in that range in between.
And then with a quality hyaluronic acid, that means that we should take with a pinch of salt trials of which have got a lower quality, and that would be a difficult thing to tease out. You'd need to take a zoom into that. Have those things been massively mixed when it comes to, say, any systematic reviews and trials?
Yeah, so this is where evidence and the world of research has its Achilles heel, right? So we're all taught to observe and practice evidence-based medicine, which we should all be doing. And part of that is being able to assess the quality of the research that you're reading, okay? And there are a lot of systematic reviews and meta-analyses out there, and they do their best to try and analyze the evidence for us, but they can only go with what they've got to work with and how these studies have been carried out. And so if you then start to apply very stringent exclusion criteria, then there would be no systemic review or meta-analysis to be able to read or learn from. And so I think it's behoven on all of us to do the research ourselves and look at what we're reading and take it with a pinch of salt as well, okay?
Do you consider hyaluronic acid to be regenerative? Would that be a word you would consider using?
No, I don't. I think I don't think it goes as far as that. I think regenerative would be the wrong term phrase to apply to hyaluronic acid.
Because I think it's interesting because it's only a word, isn't it? So you wonder if it can be applied, because you'd argue it wouldn't be applied to, say, the meniscal tissue. Yeah. However, as you've just described, ideally to stimulate some physiological response from the synovium. And so, but I think it would be a stretch. I think I'd agree with you. Yeah. But I can also understand that it's useful for people to think of it in those terms at least a little, compared to, say, an oil change or a lubricant purely. Well, sorry, I wasn't meaning steroid. I just meant that a somewhat dated idea of it being, especially when it used to be like, I'm going to drain this synovial fluid, I'm going to pump in instead this synthetic version of it, was that the agent and it being inert and stuff became this sort of something that is beyond biology. And that's one of the things I've sort of noticed in my colleagues, sort of hopefully a maturing of language to maybe regenerative is a stretch, I think that's fair, but for it to start to be acknowledged as being something more biological and has a rationale beyond it just being an oil change.
So that is a very good point, and also well made as well, right? And I think what this shows is the evolution of understanding of the clinicians that are practicing this type of treatment for patients, right? So what we're speaking to here now is the ability of a clinician to be able to explain to a person what they are proposed to do for them in terms of treatment. And so some clinicians find it very difficult to be able to explain the mechanisms or the machinations or the rationale for why you're doing something. And so in the past, a very easy and quick analogy would be something like an oil change that you've described, or a top up or whatever. And so the reason that exists is because in all of us, trying to find the right words and terminology to explain stuff to patients can be quite difficult at any level, right? Whether you're talking about an injection or whether you're talking about complicated surgery, it can be really challenging to explain what you're going to do to a patient. So I don't, criticize anybody for adopting those analogies to try and explain stuff, because it's a simplistic way to do that. And so again, in the past, it was perfectly acceptable to say it. But now, as our understanding is evolving, our language is evolving, we are now able to describe it in better terms, right? And so what you've said about a biological, physiological basis of a mode of action of hyaluronic acid, that's a good way to talk about it. Regenerative, I think that's a stretch. So it does something, it improves the physiology of the joint, okay, improves the quality of the hyaluronic acid that's being produced. It does still have a lubricant and a cushioning effect through the increased viscoelasticity of the native synovial fluid, so that it makes the joint function a bit better. But does it start to regenerate anything? So I think we have to be very careful around the word regenerate, because in recent years, a lot of clinics have popped up in the United States and some in this country offering patients regenerative approaches to this kind of problem. And I think we have to be very careful around that, and we have to be honest around that, because there's nothing out there at the moment that is going to regrow your cartilage or your tissues back to how they used to be, okay? So I think we need to stay well clear of that.
It's a really good point, in that we always want to be careful with our language and evolve it as we know more. But then, the regenerative, even as a word, has become synonymous with stem cells, with an oversale of PRP to some extent. I know we'll come to, but it's like some of the magic that's been implied is just that is magic, and it starts to get into oversales. I want to make sure I don't forget to come back to I'm interested in your opinion on saline, and potentially even talk of even saline as a therapeutic, because of the way in which seems to not be sensibly considered a placebo, and it's often the placebo that these things are controlled against. So just your take on that.
So just very quickly, I mean, there's lots of famous papers out there, right, with sham injections using saline, and my take on that will always be this, that the power of placebo is not to be underestimated. It's a real thing, okay? So you can treat a lot of people, treat a lot of conditions, not just orthopedic conditions and pain, with the power of the mind only, okay? And so if you convince someone that you've done something for them, that's a very powerful tool in itself. So saline and placebo are synonymous, in my opinion. In terms of whether injecting saline has an actual physiological effect in the joint, it probably does, because if you're injecting saline into an arthritic knee with an active inflammation and inflammatory cytokine storm in the joint, and you're diluting it with some saline, that's probably going to have some effect. Okay, so, but it's not a treatment for anything. Injecting saline into a joint is not going to treat anything actively or particularly, but it has been reported that it improves the pain and outcome, well, pain mainly, and pain perception. So.
And relevant for us to know that and to try and understand, therefore, to not wash out these trials, so excuse the pun, through poor control mediums that therefore want to imply a lack of meaningful effect between a control group and its action group, when we know that saline is probably doing more work than it wants to be implying on the trial. And sometimes that's where it's difficult. It's why we've got to read the stuff beyond the abstract, I guess,
exactly,
and where it's useful for us to just touch on. Now, before we move on to PRP, what's been interesting for me paying attention in this space a little more recently is that then we've just talked about steroid and we've just talked about hyaluronic acid can be used together, as well as then interesting new products on the market that then combine the two very thoughtfully rather than just mix and shake. So just if you could get your reflections on where the space is for where there might be room for both.
Yeah, so well, we've touched on the fact that if you're trying to preserve a joint, then don't use repetitive steroids, right? So we know that. We also know that steroids can be good for breaking the negative feedback loop of this runaway inflammation that can cause a lot of pain, okay? Now, sometimes it's impossible to get on top of that inflammation with just hyaluronic acid or PRP alone, okay? So what can you do? And there is evidence out there, and people have in the community been injecting steroid with hyaluronic acid into the joint, with sometimes good results, okay? Now, why would anybody do that, and how does it work, and what's the rationale behind that? So the rationale is we are breaking the cycle of inflammation with a steroid shot, and at the same time, we're nourishing the synovium and the cartilage with hyaluronic acid. That's the basic rationale behind doing it. Now, up until recently, there has been no product available to be able to tick both those two boxes at the same time. And so people have resorted to doing separate injections into the same joint in the same sitting. Now, steroid and hyaluronic acid doesn't combine very well, okay? If I was to get some Kenalog or Depomedrone now and get a syringe of hyaluronic acid, put them in a pot and try and mix them, they wouldn't mix, okay? And so I would actually, knowing this and getting that message out there, I would actually discourage people from doing that in itself, because what that's going to result in is a mixture of compounds that don't dissolve into each other and don't mix properly, and then sit within a joint separately, and without any of us knowing exactly where the mode of action or mechanism of action is. Are we actually causing more harm than good by doing that? Sometimes it might be fine, but in other occasions it might not be. So we're doing this completely blind. Okay,
it's a massive unknown as well.
It's a huge unknown.
You can't. It's not as if you can do good sample analysis or biopsy to something like that. That would. So it may well turn out in the fullness of time that it matters less than we're implying, but it's a hell of an experiment to be running.
Yeah, exactly. And it's a blind experiment we're running as well. There's no way of checking what's happening. We're not doing scans afterwards. No, exactly, okay, we're not doing anything. We're not scoping. We're not scanning. We're doing it, and it's blind hope, and it probably works because there are a lot of active ingredients in there, right? It's doing something, right? Sure. So it's doing something, but we can't quantify it. We can't look at it properly. But it does have a place, because we do want to get rid of that inflammation and we do want to nourish the joint. Okay, so injecting separate products together is probably off-label and off the beaten track. So I would try and avoid doing that.
And so when then thinking about the maturing of that, and so thinking about the patient profile of which it's indicated, and I can so understand myself about the sort of desire as to why that sort of almost bootlegging has occurred, is because we kind of know...
Bootlegging, that's a good word, yeah, I like it.
Yeah, the moonshine of the injection world. I was thinking that you're always going to know, the more we understand about... boggy and say background inflammation that we know is not, we know there's a chondrotoxicity that can come from that anyway. That means that then the naivety for people to think, therefore, that the nihilists of this world that are very non-interventional in any sense, they are always failing to acknowledge what are you therefore doing with the fact that unfortunately we're watching the degrading happening over time, that you're not offering solutions for these things. As to why it's a really sensible thing to try to disrupt that process, but then also for us to be feeling uncomfortable at that only being just a steroidal, that therefore is still a bit of a cross fingers beyond a few weeks or months. And therefore, you can so understand the aspiration to think, right, we'll settle that with the steroid, but then offer something more therapeutic in the hyaluronic acid. So the rationale makes sense, but the application then ends up being a reach, as we're describing. So then Singal being an example of what's come on the market for that to be not that oil and water mix that we've just been describing, where it is actually something that's made to be better integrated. Is that something that, therefore, if we were to see a profile of patient that we're describing, as we've just mentioned, that is where you would encourage, for those that are tempted to start mixing things up and crossing their fingers, the bootleggers, as I've just described it, that's where that profile of injectable would be appropriate.
Yeah, exactly. That's a very good summary of where we are, right? So there is an indication to do that, but up until now, or very recently, there hasn't really been a product that really facilitates that process. Okay, now you've mentioned Singal. Now Singal is a combined low-dose triamcinolone steroid injection mixed in with monovisc hyaluronic acid, which is of the right molecular weight. Okay, so high-dose steroids, so 40 or 80 mil. We didn't really talk about dosage of steroid actually, so we can quickly just recap on that. So to get a very good anti-inflammatory response in the joint, you're looking at a high-dose injection, usually 80 milligrams of Kenalog or depomedrone. That's a big whack, okay? And so that will then have deleterious effects on the cartilage, etc. It's good for the inflammation. It will kill the inflammation dead, no problem at all, okay? But it will harm the joint. So how can you get that dampening of inflammation without harming the joint? Singal have very kindly put together this combination injection. It's pre-mixed, so you can have a look at it. It doesn't separate out. It's going to have a uniform effect on the whole of the joint, and it's got a low-dose triamcinolone. It's only 18 milligrams rather than 40 or 80. Okay, so the negative or risk profile of injecting that level of steroid is very low and very acceptable. And actually, another interesting bit of information around Singal is that it's not classified as a medicinal product. So non-prescribing clinicians can use it in their practice and can get hold of it. So
it speaks to that accessibility point you were meaning, which we know on a pragmatic level is really important, because if there's a merry dance that someone needs to do for governance, no matter how effective the product is, it's still something that doesn't feel practical in an ever intense world where our time is money and is something that patients will lose patience as well. So it's interesting. For those that are watching rather than listening, it's been really interesting for me to see the Singal. I was expecting, even though I've heard about the rhetoric of it, I think I was still expecting it to not be almost, you still expect some maybe bubbles in it or have you, that there'll still be some, but it's clearly a well-formed product, and it's really, really interesting to see where the evidence moves in that direction. Where do you feel then, if appropriate, we could move us on to the PRP? Where is the window? And I think it's only fair because our regular listeners will certainly know that it's something that, whilst I can't think I've really been particularly vocally anti. It's definitely something that I retain a significant amount of skepticism, mainly based on it's hard to tease these things out. Why I'm excited to hear your opinion is because I'm most irritated by the overselling. I've heard it being used in synonymous terms with, like we've just talked about, with the stem cells, and that really I've found it being the application of it being somewhat regenerative, and that the lack of consideration at times for, say, a dosage or the retention of those the platelet factors local to a tissue it's trying to heal. I've been irritated by the fact that the rhetoric's been the same in joints as well as local to tendon entheses, the patient profiling. So that's where I don't want to straw man the best argument, but
Yeah.
it's just that because of that, I've ended up holding it at arm's length and ended up being someone that's never really pursued that as a personal thing I've ever done, as well as something that I have not ever referred for. And that there is an argument then that perhaps, and that's why I'm interested to hear it, that I've been a bit nihilistic. I've accused others in some spaces of being, and so I'm really keen to have my mind prized open if I have closed it off.
Okay. Right. Well, I mean, your position is a widely held position. Okay. So people who practice evidence-based medicine and treatment, there'll be a significant body of those that hold the same position as you, and rightly so. Okay. So PRP has been around for a long time as well. Okay. So the history of PRP, it goes back around 40 years plus. Okay. So it's initially a hematological product. It's been used in lots of other subspecialties like ophthalmology and aesthetics and plastics for wound care, etc. And in musculoskeletal, it's been around, I reckon, about 20 years in its current form, and it's been growing slowly in popularity. And the cultural issues that you've described have arisen from clinicians getting very excited about new ways of doing stuff, okay? And so there have been some unscrupulous actors around as well, okay? And they should be kept at arm's length, and they should be called out, rightly so, okay? Because these treatments are offered on a private basis, okay? So we're talking about members of the public who have a physical health, musculoskeletal problem and are searching for the correct solution for themselves. And then when you have a proliferation of unscrupulous actors on the market offering, holy grail stem cell regenerative solutions and injecting PRP, that is a wholly unacceptable situation. Okay, so I'm completely with you on your viewpoint of PRP in that respect, because people have muddied the waters by calling it what it isn't. Okay, so let's look at what it is, right? Let's look at what PRP does. Now, I am a proponent and a fan of PRP, okay, but it's not for everybody. Right. So in terms of we open this conversation with the golden rule, which is proper assessment and imaging and knowing where you are with your particular patient, right? Now, that applies across the board, including to PRP. So before you consider any treatment, look at your patient, assess them properly, know how much arthritis they've got. Now, platelets work by releasing... platelets are amazing, okay? So the first thing to know about platelets is they're just absolutely packed full of hundreds of growth factors, okay? Now, when they come into... So when you cut yourself, for example, if you cut yourself, how does that cut heal? It heals by platelets releasing growth factors at the site of injury, which encourage new blood vessel formation, they encourage scar tissue formation, they encourage maturation of that scar tissue into the local tissue that it should be. All of those processes are driven by the growth factors that exist within platelets, okay? And those platelets signal other cells to come to where the injury is and start doing the thing that those other cells need to do and help those other cells to mature into what they need to be. So that's how platelets generally work. Now, how do platelets... So the two main applications in orthopedics, one is tendinopathy and the other one is, more recently, degenerative joint disease like osteoarthritis. Okay, so in the last 10 years, the number of publications supporting the use in both tendinopathy and in osteoarthritis are only growing. Okay, they're growing in number and they're growing in quality. The main problem with the evidence around PRP and platelets is it's almost impossible to do a standardized experiment or study looking at what's causing the positive action from a PRP injection. There are loads of different types of PRP available on the market, different machines, different centrifugation techniques and RPMs, different volumes of venous blood that are required to be able to harvest the PRP at the end of it, different volumes of PRP that come out, different numbers of actual platelets in the sample that you're getting. There's so much variability in this equation that it's very, very difficult to pin anything down with absolute certainty. And that therein lies the question marks and the grayness in this situation, right?
And the difficulty in studying that is so obvious.
Very, very difficult to study it properly and well, but people are still trying, and positive publications are still coming out. On top of that, if I was to do a venous blood sample on you now compared to first thing this morning or after having eaten a large meal or being well hydrated, even factors like that have an impact on what quality of PRP will be harvested following centrifugation. Okay, so PRP, in my opinion, is still in the early phases of its application and development, but I think we're at a stage where it can be applied, but it needs to be applied by clinicians or teams working together who are not mis-selling it as some, panacea of all treatments, but applying it in the correct patient at the correct point in their degenerative pathway. Now, where is that?
That will be my next question. But before I do, could you just describe what you feel is the relevant and most important mechanism of action, which we have talked about on both steroid and hyaluronic acid? What do you feel is the primary mechanism of action that's relevant to this conversation?
Yeah, so the primary mechanism of action for osteoarthritis, for degenerative joint disease, is twofold. Okay, so what is the underlying problem in osteoarthritis? Okay, so the underlying problem in OA is an upregulation of matrix metalloproteinases. These are certain enzymes. So this goes into what is cartilage. Okay, so I think we could maybe do a whole section one day on what is cartilage, what is going on, what is cartilage matrix homeostasis. Within the cartilage, you have enzymes called matrix metalloproteinases, MMPs. In osteoarthritis, those MMPs are working overtime. There's always a balance between breakdown of the cartilage matrix and rebuilding of that cartilage matrix from the chondrocytes that live within the cartilage layer. Okay. Now, when the MMPs are working too hard, they're the enzymes that are responsible for breaking down the matrix of the cartilage. There's an imbalance, so actually what's happening is the overall balance is that the cartilage is being broken down and you're losing cartilage mass, okay? When PRP and platelets are applied, the platelets release the growth factors, and some of those growth factors down-regulate the function of those MMPs, so they are no longer working overtime. They come back to a normal level of function, and they stop breaking down the cartilage in an accelerated way that they were doing. At the same time, the growth factors and platelets have an anti-inflammatory effect around the joint as well. So they are very helpful in breaking down the inflammatory pathway that's also part of the osteoarthritis. So they have multiple modes of action. They downregulate MMPs, they reduce inflammation, they increase new blood vessel formation. So in the synovium of the joint and in the soft tissues where you're applying them, there's a better chance of creating new blood vessels, bringing in more cells, etc., to repair any damage.
Makes sense. Now, as I just briefly postponed us, the magic question in a way, the key one is where in the pathway then would you see this fitting? Yeah. What is the target? What is the profile of this being indicated?
Yeah. So the big rule is PRP works well in grades 1 and 2 osteoarthritis. It still works in grade 3, but to a lesser extent. But it should not be applied in grade 4. Okay. So this goes back to the initial point. Know where we are on the scale. So accessibility, availability, cost, and level of osteoarthritis. These are all factors. So PRP for me lives in the same space as hyaluronic acid. Okay. So these are joints that can be saved. They're not ready for replacement. There's enough cartilage left in the joint to try and maintain and hold on to what you've got left. So they occupy the same space. And then how do you decide about hyaluronic acid or PRP? There are a couple of factors. So if it's a patient who's got health insurance in this country doesn't recognize PRP as a treatment for osteoarthritis. PRP injections, the treatment is usually 3 injections over a course of around 6 weeks. It's not a hard and fast rule. It could be 3 weeks. Some people even do it every month, but it involves multiple injections rather than a single injection, okay? And so then there's a cost associated to that. The cost of PRP varies. The minimum cost for one injection is probably around £400, £450, something like that. So if you're talking about 3 injections, then the cost starts to mount up, okay? And so I always put it to the patient. It's completely dependent on them. I wouldn't offer it to somebody who has a very high BMI and a very degenerate joint and multiple comorbidities and is on antiplatelet medication such as aspirin or clopidogrel. So you have to take all those factors into account. If it's that kind of patient, it's not even on the table, okay?
Because you're needing to cultivate their own biology in order to utilise it, and therefore their relevant health factors are going to play a part in this.
A huge part, yeah.
Gotcha. No, it makes sense. Now, are you offering, because you share decision making and making sure we're offering it fairly, are you saying that, if say you've got someone that's sat there, fortunate enough for price not to be a factor.
Yeah, okay.
Are you offering them as sort of, I won't say synonymous, but almost as equals? Like I couldn't lend one favour one over the other on that pragmatic basis, or do you feel that there are circumstances that then tip a balance over those two offerings?
Yeah, so PRP falls into the joint preservation category, okay? So hyaluronic acid falls into the joint nourishment category, whereas PRP falls into joint preservation, right? So for me, it's always on an individual basis. So if it's an insured patient, okay, and they haven't got access to, excess funds or whatever, then we'll stick with hyaluronic acid and treat the joint with HA, and that's fine, okay? Now, if it's a patient who, money no object type patient, if they're not eligible for it, okay, and the OA is grade 4, and I think their physiology is not going to work for them, I just don't offer it. It's not about the money. It's about whether it's going to work for that patient or not, okay? And so and then on top of that are other things like, have they had joint preservation surgery, for example, a high tibial osteotomy? If they've presented with a grade 3 medial compartment varus OA, and I've corrected their alignment, in that patient, PRP is absolutely the right thing, perfect thing to do. Yeah.
And then access is really relevant then, especially in recent changes to our professional guidance and the way in which PRP has been seen quite abruptly for some people's taste. And I understand why. If people were actively using PRP as physiotherapists, it's then become clear that there is no circumstance in which that is to be insured or licensed. And
how's that come about? Has there any been?
I forget the acronym of the organisation, but it got determined to be that there was no governmental or legal framework in which it could have ever been, because you are creating a medical product, a biological and active medical product of which you are not licensed under any, and this is including your independent prescribers. There was just no mechanism. No one had ever worked that up properly. And it had just been under a radar. It got brought to a radar because of some specific questions, I think, including a legal situation on an insurance, for which then when scratched away at, it became clear that there was no appropriate process for any AHP to be delivering that, and that wasn't because there were evidence of major safety discrepancy. It was more that there'd just been a bit of clumsy complacency, and therefore it is now for at least a while yet the preserve of medical clinicians.
Okay, well, I hope that can be addressed appropriately, actually, because I think as time goes on, PRP will play more of a role in what we can offer, and appropriately qualified physiotherapists, and I work with lots of really good ones. I've trained injecting physiotherapists in my time, and I see absolutely no reason why the physiotherapists appropriately trained should not be doing this kind of treatment.
And I suspect that then a backfill will occur in the governance that means that it will be accessible again.
So,
but I think that's what happened. Is it was just a failure of appropriate regulation
of bureaucracy.
That's right, and it was quite abrupt. So in light of that context, it does really offer an interesting thing with regard to the pragmatic application of people with a degenerate knee. Then if that is for access purposes, then less on the table, if not completely, then it really does end up in that space where, because the hyaluronic acid and the PRP occupy a similar space and a similar rationale in lots of ways, then at least there's in a situation of which it's not that we're completely naked again, and that there is an availability then to a solution.
Yeah.
That's really useful. Now, I wonder if, just bringing this to a close then, that's been really interesting and a great journey through the options available.
Yeah.
I just wondered if I could get a quick glimpse, if I can, as to what you feel the next phase is. If you had to prognosticate as to where the industry's going and the way that things are going to shake out. I don't mean you have to crystal ball the evidence, that'd be brave.
Yeah.
But I mean just generally speaking as to, we sit down again, try and replicate this conversation in a few years' time. Where do you think things will have moved?
So I think the next steps in this, the evolution of this, and it's already starting to happen, is a combination of hyaluronic acid and PRP, right? So I think where it's going to go, and I'm doing some work on this as well with some collaborators at the University of Manchester and elsewhere. And what we're looking at is how can we quantify better what is happening with each sample of PRP that's taken, okay? So that's the next step in the evolution, because a bit like combining steroid and HA separately and whacking it in and hoping for the best, we've been doing a bit of that with PRP, because we get it, we don't know exactly the constituents of what we've got, but we put it in and it works most of the time, okay? 60 to 70% of the time it works, and that's a good result, and that's fine for now. But how do we make that better? How do we quantify it better? Can we have the effect of the platelets in the joint last longer? So platelets last about a week, 7 days, until they've released all of their growth factors. How can we suspend the platelets in the joint a bit longer? And is combining PRP with HA, is that a good thing? Instead of having PRP injections every 2 weeks, could we do an injection once a month if they're combined with HA? Because HA and PRP are only good, okay? There's no downsides to injecting your own platelets into your own knee or injecting hyaluronic acid into a knee. There are literally no downsides to it. The only downsides are how long will it work for? And are we doing it for the right patients and for the right reasons? They're the only downsides. And so I think in the future we'll know more about what's in it in the injection of platelets that we're delivering, and I think there'll be better combinations of PRP and HA that will be available for us to use.
No, that makes a lot of sense. I think it's an interesting to see how this all evolves, because it feels like it's gathering an appropriate pace. Yeah. And the conversation needs to be thoughtful from a mechanism of action as well as then the pragmatic application. And those things sometimes end up sitting too separately. Yeah. And I think that this is why it's really useful from, in therapies, we sometimes nicely can be a bridge between orthopedics and rheumatology. Not that you guys don't talk, but it's just that sometimes
no, we don't talk.
You can clash. And so the usefulness of all those specialties have got a lot that they need to be able to contribute to that, and especially when it comes to the pathway, we as therapists need to make sure that we're across an understanding of what that spectrum is, and to make sure that there is the silos are broken down, and that we can appropriately have these conversations maturely for the betterment of the patients, and the patient selection piece is where the interesting work is done. So I really appreciate this conversation. Thank you so much.
Thanks for having me. It's been great. Thank
Admittedly,
you very much.
on the PRP thing, I feel that there's more that we could juice to be squeezed from that conversation. But admittedly, that's something I think I need to read further on to be a worthy interlocutor to challenge that further, because it's a really interesting thing that maybe we could do
more than happy to talk about PRP in the future. Yeah.
Super. Thank
Brilliant.
you very much.
Cheers, Jack.
Nice
Thanks. Yeah, nice to meet you. Thank you.
And that's a wrap, session 104. Thanks so much to Bilal and to Jim Carr for midwiving this conversation. It was brilliant to get us together, lots of shared interest, and certainly further conversations and discussions to be had on this subject matter and more with Bilal. As I mentioned at the start, do check out eosactive.co.uk. Really interesting to keep an eye on what they're up to and follow them on socials. Jim puts out some great content on LinkedIn, for example, somewhere that some of you might not go on a regular, but it's certainly well worth doing so. And getting your head into advanced practice, and when these things are indicated, even if you're not an injector yourself. If you've been hiding under a rock, you might not know that we are the largest MSK CPD library in the world. Everything we've ever shot, from every therapy live event as well as all Physio Matters content, is on our premium service at physio-matters.com. £15 a month, £150 a year. Your price will never go up as soon as you subscribe and stay on. But we have a massive innovation coming in the new year, which is of a scale, of a a game-changing scale, I would argue, as Physio Matters was now 10 years ago, as well as what Therapy Live was 4 years ago. So I won't hint too much about what it is, but in January we are launching new content that will be on a regular basis from our best and brightest educators in our network. And it's certainly something that you won't want to miss. There will be subscription options for that exclusively, but the certainly cheapest way of getting hold of that is that our premium members that get access to all of our content, free tickets to all of our events, etc., they will be getting that, of course, included within that package. So it's already a bargain, but we're going to be bringing you lots more content on a regular basis on a multimedia format from the new year. So if you're hearing this and you want to get ahead and you want to save yourself some pennies, you like what we do, then there's no better time to join Physio Matters on there. Have a lovely Christmas. I'm really looking forward to speaking to you all and interacting into the new year, especially with what we've got planned. So all that's left for me to do is do our cheesy sign out, which I haven't done for a while. And so I was keeping it from, usually I involve the guests in that, don't I? Bilal and Jim could have involved themselves in this cheesy sign out, but I was being selfish. I wanted to hoard it to myself because it's been a while since I've said you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.